Thank you, Sushmita, for having me in your course. And by the time they put up the slides, I did ask Sushmita what exactly you want to say, and one clear message that she wants to give out is that you can catch almost 40% of the patients first with this. Then obviously the fields are obviously more sophisticated. Even in intraocular pressure, see, you have put a patient on medication. How do you know that the patient is controlled? The fields you are going to do after 6 months. So you do a diurnal control and you check that at all point times the pressure is controlled. If it is not controlled right there after 3 to 4 weeks of your medication, it's not going to be controlled later. So even if you have peaked there, you want to put in some extra medication or change your medication to get it down over there. So the very first would be the proper installation of medication and checking the intraocular pressure, which will tell you whether we are okay for the long term for the progression part. Anything else will be later. So that is first. Please do diurnal controls regularly. You need not call them or admit them. You just call them at various point times, various days while they are busy in their own practices. So this is a split diurnal control. And then you see whether everything falls into place. Fields and gonioscopy, we'll talk. This is what we were talking about, that obviously the first step is that the RNFL goes. The first thing is that the ganglion cells die and you can see them wry over there, the axons are not there. That then later shows into the disc, and then it is the functional damage of the visual field. So a number of those are dead before the visual field will show you some changes. By and large, sometimes yes, with the tessellated fundus you may not be picking up the RNFL, or the disc changes may not be so apparent to you in a small disc or something like that, and the visual field may throw up a change first. But by and large, please remember, if it is not an advanced, if it is an early damage, look for the structural changes. I am sick of seeing people throw at my face, sir, hum OCT kara ke aa gaye. And he has got 0.9 cupping in both the eyes, one eye is blind, and somebody has done an OCT because he has bought a machine, so he has to do an OCT. I am sick of those people. Don't do an OCT for a patient who has an advanced damage. It's not going to give you anything. The only thing that will work for you is either a structural thing or a visual field. So I'll just show you how this works. So you have we had a patient over here. I keep showing this for various things. Thick corneas, IOP varying between 20 to 24. OCT was normal, field was normal, everything was normal, disc is okay. You can see the striations are beautiful, so we just let it be. And the first change that occurs is, you can see here, there is a wedge defect over here. So that is the first thing. There is no notch also. So the first structural change is a wedge defect that shows the RNFL change. The field is still normal. And then you go on and you see that yes, there was a pre-perimetric change that the OCT which has detected. So it was the first change was, these are the places where an OCT is important. When nothing else is being seen, everything looks normal, but you do an OCT and you find that this change is there. Please learn to read the disc beautifully. So you know that the inferior disc is the thickest, followed by the inferior rim is the thickest, followed by a superior nasal. If this is not there, means there is a progression. Keep checking for the RNFL. And normally a disc hemorrhage, yes, I would say that it is a harbinger of something that is going to happen. Something is not right. There is progression. You have to be alert. You have to be more aggressive in your treatment. Again, if there is a generalized rim thinning, that means there is progression. If you see that the wedge defect has become wider and the notch is becoming deeper, there itself you can check that yes, you don't even need to do a field. You know that things are progressing worse than what it is. As Dr. Vinay showed, the beta zone of atrophy can increase. And obviously, if you have frank notch appearing where there was none before, you know that something is not right. Bearing of the circumlinear, keep track of these vascular signs. You see a vessel over there which was lying in the rim like this vessel, but that means the rim has disappeared. Some of the axons have died and left this thing hanging over there. The same with the overpass cupping. This vessel has been lying hanging and soon it will drop. This means that some of the rim tissue has been lost. So these are the early changes that you can detect by disc itself, and everybody can do a good disc examination. I know in some places even the fields are not available. So please be very, very friendly in examining the disc. You can do great job by doing just that. Obviously, functional progression is great. Visual field progression, yes, you have to have a visual field in order to be a glaucoma specialist of some extent. Obviously, new defects are rare. The more important, almost 80% are detected because there's enlargement of a pre-existing defect or the deepening of the defect. And the criteria variously we follow is the trend or the event analysis. Between the previous and the first field is event-based analysis, and a trend-based analysis basically means we have a number of good fields which are done and which will show us that things are going down. And please remember, you must have two visual fields done immediately together which are similar in nature, that will tell us that yes, things are going down. And obviously you can have a change probability which actually takes the mean deviation, and you can see that things are going from bad to worse, and it will ultimately give you a analysis also that yes, the things are falling down and you need to do something because the chap is progressing. So this is a event-based analysis. From first to second, you can see the black triangles have increased, so things are there, and you do the other one and you know that there's a progression. Now obviously we have moved on to GPA analysis, the glaucoma progression analysis, which will again highlight for you the machine. If you have a number of reliable fields, it will highlight for you immediately whether there's a possible progression or there's a likely progression, but you have to have a number of fields with a good baseline which will tell you that this is happening. What we currently use is the visual field index, which is actually is based both on the pattern standard deviation and the total deviation, but it is more centrally weighted. So it's a very good tool, and what it tells is if you have good baselines, you can actually find out the rate of progression, and you find that you can actually estimate the velocity of progression, and you know in 5 years where the patient would be. So this is a really good tool which will tell you what exactly is happening, how aggressive you have to be in your management of this patient. And there you see that a patient who had, Sushmita, 1 minute, 2 minutes, chalega? 1 minute, huh? So, so a patient who had such beautiful fields is rapidly dropping, and you can see that the rate of progression is enormous. So you know he's a young patient, 40 years old, dropping at this 8% per year means he is soon be in serious trouble, so you have to be very, very aggressive. The problem is with the fields is that there's a lot of learning effect, and that's why we said that you must have two baseline good fields, because this patient has been improving over the couple of fields. Same with the box plot. There is a long-term fluctuation. That means that the fields were normal, were better, then they become worse, then they became better, so sometimes that may be difficult to interpret. If you have already a bad field like this, please be careful, don't go on to the analysis, just go point to point, read all the points and check point by point whether it is decreasing or not. That's the only way to learn that. There may be associate pathologies. Please also keep checking your gonioscopies. This is what we keep forgetting. So angle closure glaucomas, if the angle was only closed in 90 degrees and now you see it's closed in 360 degrees, you know you are in for trouble. So this is another progression that you please keep monitoring. Again, to remind you, the first changes would be in the RNFL, followed by DISC, followed by visual field by and large. Thank you very much.